All right, everyone, we've made it to the final week of the semester and the course. I really hope that you've been, at the very least, learning, hopefully, even enjoying the content that we've been covering in class. So, I would like to finish this class talking about where we're going in this field and what type of modalities we might be employing moving forward, or hopefully even inspire some ideas from y'all about where we might be able to go. So, starting in the text, talking about the therapeutic potential of synthetic tryptamines, let's get into it. All right, so this chapter begins by situating fast-acting tryptamines within the broader psychedelic renaissance. As you've seen throughout this course, substances like psilocybin and MDMA have demonstrated strong efficacy across a range of clinical conditions like PTSD, depression, anxiety, and substance use disorders. However, the authors highlight a critical structural limitation. These treatments are resource intensive. A single session can last 4 to 6 hours, requiring multiple trained providers, dedicated space, and extensive preparation and integration. From a systemic lens, this raises an immediate equity concern. Who actually gets access to these treatments? As the authors note, high cost disproportionately excludes already marginalized groups like people of color, LGBTQ plus populations, and veterans. Fast-acting tryptamines are introduced as a potential solution. Because of their rapid onset and short duration, they may dramatically reduce cost and expand access, though, as we'll discuss, this introduces new ethical and clinical tensions. Duration is not just a pharmacological detail, it's a systems level variable. Long sessions require multiple therapists or sitters, guides, dedicated treatment rooms, and extended monitoring. This makes psychedelic therapy inherently difficult to scale within traditional healthcare systems. Fast-acting tryptamines, by contrast, compress the experience into a much shorter window. For example, DMT peaks within minutes and resolves within about 20 to 30 minutes. From one perspective, this is revolutionary. It opens the possibility of shorter clinical encounters, lower cost, and integration into settings like hospital or crisis units. From a relational perspective, we have to ask, what is lost when we compress the therapeutic container? Does time mean less integration during the experience, more intensity with less relational scaffolding? This is the key tension for this entire reading. DMT is one of the most fascinating compounds in the psychedelic landscape because it is both endogenous and exogenous, meaning it occurs naturally in the body as well as in plants. Pharmacologically, it interacts with a wide array of receptor systems, not just serotonin, but also dopamine and glutamate pathways. This complexity likely contributes to the intensity and uniqueness of the experience. Clinically, what stands out is the speed. Effects begin within minutes. You peak rapidly, and there's a resolve within half an hour. From a therapist perspective, this creates a very different therapeutic arc compared to psilocybin, which is there's less gradual unfolding, more abrupt entry into altered states, and potentially less time to stabilize or orient. So, talking about DMT in comparison to psilocybin. This raises important clinical questions about preparation and containment. One of the most striking aspects of DMT is its phenomenology, how people actually experience it. Participants frequently report encountering entities, entering alternative realities, receiving messages or insights. These are not mild perceptual distortions. They are often described as more real than reality itself. Importantly, many individuals rank these experiences among the most meaningful or spiritually significant events of their lives. From a clinical standpoint, the content of these experiences often includes insight into addiction, confrontation with morality, and recognition of relational disconnection. Here's where your relational lens becomes crucial. These experiences may often reorganize how clients see themselves in relation to others. For example, they may say things like, "We are all connected," or my behavior is hurting my family. These are fundamentally systemic insights, even when the experience appears intrapsychic. Although controlled clinical trials are still limited, the authors suggest that DMT may produce therapeutic effects through both biological and psychological pathways. Biologically, there is emerging evidence for anti-inflammatory effects, neurobiological changes linked to depression, and psychologically, the mechanism appears similar to what we've seen within psilocybin, mystical-like experiences, deep emotional insight, and meaning making. Crucially, the authors emphasize that these benefits are most likely when DMT is used in conjunction with psychological support. This reinforces a core theme for our course. The medicine is not the therapy, the relationship is. 5-MeO-DMT is often described as even more intense and sometimes less visual than DMT. Pharmacologically, it differs slightly in receptor binding, with stronger activity at the 5-HT1A receptor, which may relate to emotional intensity, ego dissolution, and reduced visual imagery. Clinically, the experience is often described as profound unity, ego dissolution, and deep emotional release. But importantly, it can also be overwhelming, disorienting, and physically dysregulating. This again raises questions about clinical containment and safety. One unique phenomenon with 5-MeO-DMT is reactivation, where individuals re-experience aspects of the drug effects later, often during sleep or meditation. While most people report these as neutral or even positive, from a clinical perspective, this raises important concerns. What does informed consent look like here? How do we prepare clients for delayed effects? Additionally, the intensity of the experience can be difficult to regulate, which may increase risk for dysregulation and require more robust preparation. This challenges the idea that shorter equals easier. DPT is less well known, but has a fascinating clinical history. In the 1970s, it was used in alcohol use disorder treatment and cancer-related existential distress. Unlike DMT, DPT was sometimes used in structured psychotherapy contexts, including manuals for DPT-assisted talk therapy. At lower doses, it may enhance emotional access and verbal processing. This is especially interesting from an MFT perspective because it suggests a potential bridge between psychedelic states and ongoing relational dialogue. Across all three substances, the proposed mechanism is similar. They induce peak or mystical experiences, and these experiences are associated with lasting change. This aligns with broader psychedelic research showing that the intensity and meaning of the experience, not just the drug, predict outcomes. However, the authors emphasize a key advantage. Short duration leads to increased feasibility in clinical settings. This could allow use in hospitals, emergency departments, and inpatient units. But again, we must ask, can profound transformation be safely facilitated in compressed timelines? The authors end with a forward-thinking vision. These substances could potentially be used in high acuity settings, including emergency departments, inpatient psychiatry, and detox units. This is a major shift from the current model of carefully curated, day-long psychedelic sessions. From a systemic perspective, this raises profound questions. Are we moving toward medicalization and efficiency at the cost of depth? What happens to the relational container in fast-paced settings? Who controls access, healthcare systems, private clinics, or communities? This reading really captures the core tension of week 15. The future of psychedelic therapy is not just about what works, it's about what kind of field we are building. All right, so our final reading in our textbook, The Ibogaine Project, Urban Ethnomedicine for Opioid Use Disorder. Ibogaine represents a very different kind of frontier modality compared to what we saw with fast-acting tryptamines. Rather than emerging primarily from laboratory science, ibogaine originates in indigenous spiritual practice, specifically within the Bwiti religion in West Central Africa. In that context, iboga is not simply a drug, it's a sacrament, a relational and communal experience, and a way of connecting across time with ancestors and space, your community. When ibogaine enters Western medicine, however, it becomes a tool for opioid detoxification and a substance often in informal or underground settings. This transition reflects a major theme of this course, the movement from relational cultural healing into individualized medical interventions. The author uses the term urban ethnomedicine to describe ibogaine's current use. This is important. It highlights that ibogaine treatment exists outside traditional healthcare systems and is often developed and delivered by non-traditional providers. Historically, its use in addiction treatment began with a non-clinician, Howard Lotzev, who discovered its effects serendipitously. From a systemic perspective, this is fascinating. Innovation is not coming from institutions, it's coming from marginal spaces and lived experience. But it also raises concerns. There's a lack of regulation, there's variable safety practices, and unequal access to quality care. The typical ibogaine treatment protocol is quite structured, even in informal settings. The test flood booster model reflects an attempt to balance safety and effectiveness. It's a recognition of variability in opioid dependence. Clinically, the goal is remarkable. You want to interrupt opioid withdrawal rapidly, often within days. Compare this to traditional treatments like methadone, buprenorphine, and buprenorphine. Ibogaine is positioned as a disruptive intervention, not a maintenance therapy. From a relational lens, this raises questions. What happens after detox? Where is the relational holding environment post-treatment? The data on ibogaine are compelling, but also limited. Studies show that it has a rapid and substantial reduction in withdrawal symptoms, and some individuals maintain abstinence months later. Importantly, many of these participants had failed traditional treatments and were highly treatment resistant. However, the research has limitations. It's often observational, and there's a heavy reliance on self-report, and there's a lack of randomized controlled trials. So, from a critical standpoint, ibogaine sits in a space of high promise and low standardization of evidence. Ibogaine's subjective experience or effects are quite distinct from other psychedelics. Rather than purely visual or mystical states, it often produces a structured narrative experience and a kind of guided introspection. The slideshow phenomenon, which is rapid recall of autobiographical memories, is particularly important. Even more clinically significant is the reported emotional equanimity. These are painful memories that are revisited, but without overwhelming affect. From a therapy perspective, this is profound. It creates conditions for trauma processing without dysregulation. This is where ibogaine strongly aligns with our relational and systemic framework. Participants frequently report renewed connection to family, a sense of belonging across generation, and a repair of relational ruptures. In fact, one of the most improved domains in studies is family and social functioning. This mirrors concepts of binding across relationships and healing through connection. So while ibogaine is often framed as an individual detox tool, it affects our deeply relational, intergenerational, and systemic. One of the most fascinating aspects of ibogaine is that its mechanism is not well understood. It does not function like methadone, which is an opioid agonist, classic psychedelics, which function on or affect the 5-HT2A receptor. Instead, it appears to modify addiction-related brain pathways and reduce drug craving and salience. And it also potentially resets neuroadaptations. This positions ibogaine as a fundamentally different paradigm of addiction treatment. Ibogaine biggest limitation is safety, particularly cardiac risk. It can prolong the QT interval and lead to dangerous arrhythmias. In some cases, it can result in death. This makes proper medical screening essential. If that person has a cardiac history, like looking at their electrolytes and having continuous monitoring. However, many ibogaine treatments occur in underregulated environments and without adequate medical oversight. This creates a major ethical tension between access and safety. Ibogaine is not just a treatment, it's a prototype for future medications. Researchers are developing analogs like 18MC, which aim to preserve therapeutic effects and reduce cardiac risk. This reflects a broader trend of using psychedelics as templates for drug discovery. This reading brings forward some of the most important ethical questions of this course. The first of cultural appropriation. Iboga originates in Bwiti traditions, and Western use often removes cultural context. Then there's a question of medicalization versus relational healing. Indigenous use is communal and spiritual, and Western use is an individual detox. Then there's the aftercare gap. Detox is not recovery. So, what relational systems support long-term change? And then the ethical consideration of risk tolerance. People seek ibogaine when other treatments fail. So, how do we balance autonomy and protection? All right, ibogaine represents a fundamentally different vision of treatment. It's rapid, intense, and transformative, but also it's risky, under-researched, and systemically complex. The central question becomes, can we integrate ibogaine into healthcare systems without losing its depth or compromising safety? All right, so then we move to our article on single treatment with MM120 in generalized anxiety disorder. So this study represents one of the most important shifts in psychedelic research. We're moving into large scale pharmaceutical grade clinical trials. This was a randomized, double-blind, placebo-controlled trial. It was conducted across 22 sites in the US. So participants had moderate to severe generalized anxiety disorder. So they, on the HAM-A, they had a score greater than or equal to 20, and there was significant functional impairment. So the key innovation here is a single dose intervention with long-term follow-up. So this challenges the dominant psychiatric model of daily medication and chronic symptom management. So generalized anxiety disorder is one of the most common psychiatric disorders, yet treatment remains limited. So some key issues with this. SSRIs there's often just a partial response to it. Benzodiazepine has dependency risks. And psychotherapy, it's helpful but not universally effective. Importantly, about half of patients don't respond adequately to first-line treatments. So this creates a massive treatment gap. There's chronic suffering, functional impairment, and high comorbidity. This study is attempting to answer, can a single psychedelic experience produce sustained relief? One of the most important and controversial features of this study is that psychotherapy was explicitly prohibited. Participants could not receive therapy during sessions, and only supportive monitoring was allowed. So why was this the case? They wanted to isolate the drug effect alone. This is a major departure from like MAPS, MDMA model, or psilocybin-assisted therapy. From a relational perspective, this raises a key question. What happens when we remove the relational container? Even though psychotherapy was prohibited, the setting still reflects classic psychedelic protocols. So there's an aesthetic, calming room, eye shades and music were used, and there's continuous interpersonal presence. This is critical. The study claims no therapy, but relational elements are still present. There were 2 monitors who provided support, ensured safety, and responded to needs. This highlights attention. Is supportive presence itself a form of therapy? So the main finding is that higher doses significantly reduced anxiety. So at 4 weeks, at 100 milligrams, there was a clinically meaningful reduction. And at 200 milligrams, there was a slightly stronger effect. So lower doses at 20 and 25 and 50 were not effective. So this establishes a clear dose response relationship, which is critical for FDA approval pathways. This is one of the most striking findings: rapid onset plus long duration. Participants showed improvement within 24 hours and sustained benefit for 3 months. So if we compare this to SSRIs, they take weeks to months. Benzodiazepines are only short term, they only work short term. And even more compelling, about 65% achieved a clinical response. Nearly half reached remission. So this suggests a transformational intervention, not just symptom suppression. Although this was a GAD study, or generalized anxiety disorder, effects extended beyond anxiety. Participants showed reduced depression through the MADRS scores and improved functioning. This aligns with broader psychedelic findings. Effects are often transdiagnostic, so they're not disorder specific. From a systemic lens, these changes likely impact relationships, but the study does not measure relational outcomes directly. Safety findings are important. The most adverse effects were expected psychedelic effects, like things that we expect to happen when psychedelics are taken. They're time limited and they resolved within the session. So if there were any adverse effects, they didn't last long, and by the time that they were out of the drug administration, they had resolved. Notably, there were no serious drug-related adverse events and no increase in suicidality. So this supports short-term safety in controlled settings. This is arguably the most important critique. This study claims drug-only effects, but in reality, participants had 2 trained monitors. They received preparation and follow-up, and they were in a carefully curated environment. The authors even acknowledge interpersonal interaction may have influenced outcomes. So for this class, it challenges the idea that psychedelics can be fully decontextualized from the relationship. Blinding is a major issue in psychedelic studies psychedelic trials, as we've talked about, because the effects are obvious and participants often know. So they'll say things like, I got the drug. Despite this, placebo effects were still strong. Lower doses did not show efficacy. And this suggests that effects are not just expectancy, but expectancy still plays a role, and that meaning-making processes likely matters. The proposed mechanism combines biological, so serotonin receptor activation and brain network changes, and psychological, which altered perception and emotional processing. There's also the temporal paradox. The acute experience leads to long-term change, and this aligns with the idea of a therapeutic window of plasticity after dosing. So compared to existing treatments, so SSRIs have a moderate effect size of about 0.36. So remember, this is from -1 to 1, so 0.36 is quite small. Psychotherapy, which has a larger effect of 0.76, but it's slower. And then with LSD or MM120, it's comparable or has stronger effects, and there's a much faster onset. So this positions psychedelics as a potential paradigm shift in psychiatry. This study raises critical tensions. So in terms of medicalization, LSD is a pharmaceutical product, MM120. It's controlled, standardized, and scalable. There is also the issue of decontextualization, so the removal of psychotherapy, and there's a focus on drug effect. There's the relational gap, so there's no structured integration and no attention to family or system contexts. And then the question of equity, so who gets access to these treatments? This study represents the most mainstream version of psychedelic care as we've seen such so far. So it's pharmaceutical, it's scalable, and it's evidence-driven, but also it's stripped of relational depth and focused on individual symptom reduction. So the core question for y'all is what is lost and what is gained when psychedelic therapy becomes medicine? All right, so talking about the magnesium ibogaine therapy in veterans with TBI. So this study is situated within a very specific and clinically complex population, Special Operations Forces veterans who have experienced traumatic brain injuries, often due to repeated blast exposure. As the authors describe, TBI is not only a major cause of disability worldwide, but it is also highly prevalent among military populations, where it is often referred to as the signature injury of modern warfare. These injuries are rarely isolated. They tend to co-occur with psychiatric conditions like PTSD, depression, and anxiety, as well as cognitive impairments that affect attention, memory, and executive functioning. Importantly, these individuals are at significantly elevated risk for suicide, which underscores the urgency of identifying effective interventions. However, current treatment approaches, including psychotherapy, medications, and rehabilitation, are often insufficient, particularly for veterans. This creates a context in which individuals may seek alternative treatments, including those that are not widely available or fully validated. Ibogaine is a plant-derived compound that has a unique place in the psychedelic landscape. Unlike more commonly discussed substances like psilocybin or LSD, ibogaine is often described as a wunderjawn, meaning it induces dreamlike states of consciousness. These states are typically characterized by extended internal experiences, often involving autobiographical reflection, emotional processing, and vivid imagery. Pharmacologically, ibogaine is quite complex. It interacts with a wide range of neurotransmitter systems, including opioid, serotonin, dopamine, and NMDA receptors. It also appears to increase neurotropic factors such as BDNF, which are associated with neuroplasticity and brain repair. This combination of neurobiological and experiential effects has led to interest in ibogaine as a treatment for conditions such as addiction and now increasingly for trauma and brain injury. It is also important to recognize that ibogaine has a long history of use in African spiritual and healing traditions, which adds another layer of meaning and raises questions about how these practices are translated into Western clinical contexts. Despite its potential, ibogaine carries significant safety concerns, particularly related to cardiac functioning. The most serious risk is QT interval prolongation, which can lead to fatal arrhythmias. These risks have limited its clinical use and contributed to its classification as a substance or Schedule 1 substance in the US. The innovation of the study is the use of magnesium as a co-treatment. Magnesium is known to stabilize cardiac rhythms and reduce QT prolongation. And the authors propose that combining magnesium with ibogaine may mitigate these risks. The combined protocol is referred to as MYSTIC, MISTIC. This is important because it reflects a broader trend in psychedelic research toward modifying or optimizing compounds and protocols to improve safety and feasibility. Methodologically, this is a prospective observational study rather than a randomized controlled trial. 30 male veterans participated, all of whom had already independently chosen to undergo ibogaine treatments. This is a crucial detail because it introduces several sources of bias, including self-selection and expectancy effects. Participants were assessed before treatment, immediately after, and 1 month later. However, because there is no control group, we cannot definitively attribute observed changes to the treatment itself. This is a common limitation in early stage psychedelic research, especially when studying treatments that are not legally available in the US. Still, the study provides valuable preliminary data, particularly given the difficulty of conducting research in this population and with this substance. The treatment itself took place in a clinic in Mexico where ibogaine is not prohibited. Participants underwent a structured protocol that included both pharmacological and non-pharmacological elements. In addition to receiving ibogaine and magnesium, participants engaged in preparatory coaching, group activities, and integration support. They also had access to complementary practices such as meditation, breathwork, and yoga. These elements are important because they create a rich therapeutic context, even though the study is framed primarily in terms of pharmacological intervention. From a systemic perspective, this raises an important question. How much of the observed change is attributable to the drug itself versus the broader therapeutic environment? The primary outcome of this study was functional disability, measured using the WHO-DAS scale. I don't know if that's like HOODAS. Participants showed significant improvement immediately after treatment and even greater improvement at the 1 month follow-up. This is particularly what is particularly striking is the magnitude of change. Participants moved from mild to moderate disability at baseline to levels that were close to no disability at 1 month. These changes were associated with large effect sizes, indicating not just statistical significance, but meaningful clinical impact. This suggests that the intervention may be affecting not only symptoms, but also broader functioning and quality of life. In addition to improvements in functioning, the study found dramatic reductions in psychiatric symptoms. PTSD, depression, and anxiety all decreased significantly with very large effect sizes, greater than 2, which is rare in clinical research. Response and remission rates were also exceptionally high, exceeding 90% and 80% respectively. Perhaps most strikingly, suicidal ideation dropped from nearly half of participants at baseline to none immediately after treatment. While these findings are promising, it's important to interpret them cautiously, given the lack of a control and the potential influence of other factors. One of the unique strengths of this study is the inclusion of neuropsychological testing. Participants demonstrated improvements in several cognitive domains, including processing speed, executive functioning, and attention. Importantly, these are objective measures, which are generally less susceptible to placebo effects than self-report data. The study also found no evidence of cognitive decline, which is particularly reassuring, given prior concerns about ibogaine's potential for neurotoxicity. The findings suggest that the intervention may have not only psychological benefits, but also neurocognitive effects. Despite the promising results, the study has several important limitations. The lack of a control group means that we cannot determine causality. Participants self-selected into treatment, which introduces bias, and the intervention itself was highly complex, involving multiple therapeutic elements beyond ibogaine. Additionally, the follow-up period was relatively short. The sample was highly specific, so they were male special operations veterans, which limits generalizability. These limitations highlight the need for more rigorous, controlled research to better understand the effects of this intervention. Overall, this study provides some of the most compelling preliminary evidence to date for the potential of ibogaine, particularly when delivered within a structured and supportive context, to produce meaningful improvements in both psychological and functional outcomes. However, it also raises important questions. What is actually driving these changes? Is it the pharmacological effects of ibogaine, the therapeutic environment, the relational support, or some combination of all three? From a systemic and relational perspective, this is perhaps the most important takeaway. Healing may not be located solely in the substance, but in the interaction between the substance, the individual, and the context in which the experience occurs. All right, so our final reading for the course. So we will call it Pala from the School of Hana. This reading is quite different from the others this week. Rather than presenting empirical data or clinical outcomes, it offers a visionary and philosophical reflection on what the future of psychedelic work could look like, drawing inspiration from Aldous Huxley's novel Island. The authors imagine a society they call PALA, where healing is not confined to clinics or medical systems, but it is embedded within community, culture, and daily life. What makes this piece particularly important for this course is that it challenges a dominant trajectory we've seen in the other readings, namely the movement toward medicalization, standardization, and pharmaceutical control. Instead, it asks us to consider what it would mean to build systems of care that are relational, ethical, and culturally grounded. A central critique of this article is the medicalization of psychedelics. As we saw in the LSD study, there is a strong push to develop psychedelic treatments that fit within existing healthcare and pharmaceutical systems. While this increases legitimacy and scalability, it also risks reducing these substances to mere tools for symptom reduction. The authors argue that this process can strip psychedelics of their deeper meanings, spiritual, relational, and cultural, and relocate healing within the individual rather than within relationships or communities. This critique directly contrasts what with models like ibogaine in Bwiti traditions, where healing is inherently communal and embedded in shared meaning systems. The concept of Paula functions as both a metaphor and a guiding vision. In this imagined society, healing is not something that happens in isolated clinical encounters. It is woven into the fabric of everyday life. People are supported not just by therapists, but by communities, rituals, and shared values. This is a fundamentally systemic perspective, one that aligns closely with family therapy principles. It recognizes that individual suffering is often embedded within relational and societal contexts and therefore requires relational and collective responses. The article emphasizes that healing is inherently relational. Rather than focusing solely on individual insight or symptom reduction, it highlights the importance of shared experiences, rituals, and communal meaning making. This is particularly relevant for y'all. It invites you, to consider how psychedelic work might be integrated into relational systems like couples, families, and communities, rather than remaining an individual intervention. The article also raises important ethical concerns. As psychedelics gain popularity, there is increasing risk of exploitation, whether through profit-driven models, misuse of power by facilitators, or appropriation of indigenous practices without proper acknowledgement or reciprocity. The authors call for a model of practice grounded in integrity, humility, and responsibility. This includes recognizing the historical and cultural origins of these substances and ensuring that their use does not replicate patterns of harm or extraction. Another key idea is that therapy is only one part of a much larger system of healing. The authors argue that meaningful change requires ongoing support, education, and opportunities for integration beyond a single session or even a course of treatment. This aligns with what we've seen across this course, the importance of integration as a continuous process, not a discrete phase. It also challenges therapists to think beyond the confines of their professional roles and consider how they can contribute to broader systems of care. So this slide highlights the central tension of the article. On one hand, we have the current trajectory of psychedelic research and practice, which is moving toward clinical trials, FDA approval, and standardized treatment protocols. Then on the other hand, we have the vision of Paula, which emphasizes decentralization, community, and relational care. These two models are not necessarily incompatible, but they do reflect different priorities and values. This tension is likely to shape the future of the field in significant ways. So, for marriage and family therapists, this reading opens up important possibilities. It suggests that MFTs are uniquely positioned to contribute to the future of psychedelic work by bringing a relational and systemic perspective. So, this could include involving partners or family members in preparation and integration, addressing relational patterns that emerge during psychedelic experiences, and participating in or helping to build community-based models of care. In many ways, this reading invites MFTs to move from the margins to the center of this emerging field. Rather than providing definitive answers, the article leaves us with a set of critical questions. These questions are not just theoretical, they have real implications of how the field develops, who benefits, and what kinds of practices are prioritized. This is especially important for students to sit with as you move into your professional roles, where you'll be participating in shaping this field. The central takeaway from this reading is that psychedelics are not just clinical interventions. They are tools that shape culture, relationships, and systems of care. The future of the field will depend not only on scientific evidence, but on the values and priorities of those involved. This brings us back to the overarching theme of the week. The future of psychedelic therapy is not predetermined. It is something that is actively being constructed, and as future clinicians, y'all will play a role in this process. All right, so leaving you with this, y'all. As we close this course, this slide is meant to hold the central tensions that have emerged across all of the readings, not to resolve them, but to help us think more critically about the future we are participating in. The first tension is between efficiency and depth. In the first reading, we saw the promise of fast-acting tryptamines, shorter sessions, lower cost, and greater scalability. At the same time, we are left with an important question. What might be lost when we compress these experiences? Psychedelic work has traditionally relied on time for preparation, for the unfolding of the experience, and for integration. If we reduce that time, are we also reducing the depth of the work or changing its nature altogether? The second tension is between medicalization and relational healing. The LSD study represents perhaps the clearest example of psychedelics being integrated into a pharmaceutical model. Standardized dosing, controlled environments, and an intentional removal of psychotherapy to isolate the drug's effects. In contrast, excuse me. In contrast, the ibogaine readings highlight models of care that are inherently relational, communal, and embedded in meaning-making systems. This raises a fundamental question. Can psychedelic healing be separated from relationship, or is relationship an essential component of the process? Third, we see a tension between pharmaceutical control and community-based care. Clinical trials and FDA pathways offer legitimacy, safety, and scalability, but they also centralize power within medical and corporate institutions. The Paula vision challenges this by imagining decentralized, community-rooted systems of healing. These two trajectories are not mutually exclusive, but they reflect very different values about who should control access to these substances and how they should be used. The fourth tension is between individual change and systemic transformation. Much of the research focuses on symptom reduction at the individual level, so reductions in anxiety, depression, or PTSD. However, many psychedelic experiences themselves are deeply relational, often involving insights into family, connection, and interdependence. From a systemic perspective, we might ask whether true healing requires not just individual change, but changes in relationships, communities, and broader social systems. Finally, there is a tension between access and safety. Fast-acting substances, scalable models, and expanded access all hold promise for reaching more people. At the same time, these approaches introduce new risks, whether related to medical safety, ethical practice, or the potential of exploitation. The ibogaine readings, in particular, highlight what can happen when people seek care outside regulated systems because existing systems have failed them. So, taken all together, these tensions point to a central reality. The future of psychedelic therapy is not fixed, it is being actively constructed. And importantly, it is not being constructed only by researchers or pharmaceutical companies, but also clinicians, communities, and clients. So, for you, an emerging therapist, this raises a final question. What role do you want to play in shaping this field? Will you align more with medical models, relational models, or some integration of both? How will you navigate issues of ethics, access, and power? And how will you ensure that as this field grows, it remains grounded in care, responsibility, and human connection? This is not just a clinical question, it is a professional and ethical one. So thank you all so much for hanging with me this semester. I look forward to all of your feedback on the content, the delivery, all of that. But thank you for your attention.